In this lecture, we're going to take a look at the acute neurologic condition of a cerebrovascular accident, otherwise known as a CVA or stroke. The brain requires a continuous supply of blood to provide oxygen and glucose to the neurons in order for them to function properly. The brain generally requires about 20% of the cardiac output to function effectively. A stroke occurs when there's inadequate perfusion to a portion of the brain. This can be caused by ischemia or hemorrhage. Either of these situations can interrupt the blood supply to the brain and ultimately result in death of the brain cells. Ischemia occurs when there's a blockage inside the vessel. It could be something such as a blood clot, known as an embolic type of stroke, or it can be plaque, which causes a thrombotic type of stroke. Atherosclerosis is a major contributor to ischemic strokes. It causes hardening and thickening of the arteries. It leads to thrombus formation and contributes to the development of emboli. A hemorrhagic type of stroke occurs when the blood leaves the vessel and enters the extravascular space. Some common reasons that hemorrhagic strokes can occur could be due to a vessel rupturing as a result of severe hypertension. It also can come from a weak spot in the vessel, such as an aneurysm that ruptures. Regardless of the cause, once the blood flow to the brain stops, metabolism will stop in about 2 minutes and cell death will begin to occur within about 5 minutes of the interruption of the blood flow to that particular part of the brain. With this being said, we understand that time is an important factor in identifying a stroke and getting treatment, and it's necessary to act fast. FAST is an acronym used frequently in public service announcements as a mnemonic to help the public detect the warning signs of a stroke and to enhance the responsiveness to the needs of a person having a stroke. The acronym FAST stands for F, facial drooping, A, arm weakness, S, speech difficulty, and the T stands for time to call help or 911. Facial drooping can appear in just a section of the face, and it usually often appears on just one side. The face will be drooping and it will be hard to move. This can oftentimes be recognized as a crooked smile in the individual. Arm weakness can be seen as their inability to fully raise their arm. Speech difficulties could be from an inability or a difficulty to either understand speech or difficulty in producing speech. And as far as the T for time goes, if any of those above symptoms are showing in an individual, time is absolutely of the essence, and calling emergency services and going to the hospital immediately is critical at that point. Some additional warning signs of a stroke could include not just the weakness in the face and the arm, but also even the possibility of numbness or paralysis in the face and the arm, and not just face and arms, but legs as well, especially on one side of the body. The patient may experience some sudden confusion. As mentioned already, trouble speaking or understanding speech falls under that S in our FAST acronym. Slurred speech is also another potential warning sign that we could be seeing. Additional warning signs could include trouble seeing in one or both eyes. They may have trouble walking, some dizziness, a loss of balance or coordination. Oftentimes, individuals also report a severe sudden headache with no known cause, and it's even been referred to as a thunderclap type of headache. As we take a look at the non-modifiable and the modifiable risk factors for a stroke, we see a lot of similarities to both the non-modifiable and modifiable risk factors of heart disease. Things that we can't do anything about are going to be age. The older an individual gets, the more likely they are to suffer from a stroke. About 2/3 of individuals over the age of 65 will suffer a stroke at some point. Being of the male gender or the African American race. African Americans are twice as likely to die from a stroke as other races. Hispanics, Native Americans, and Asians also are at higher risk for strokes than Caucasians. Having a family history of a stroke is something else that we can't do anything about. Genetic risk factors are important in the development of any type of vascular disease, including a stroke. So definitely a person with a family history of a stroke is going to be at higher risk for having one. Anybody with a history of a TIA. A TIA stands for a transient ischemic attack, which we will discuss shortly. We then have our list of our modifiable risk factors. These are the things that we can do something about. And again, as I already mentioned, it's very similar to those risk factors associated with cardiovascular disease. Hypertension is the single most important modifiable risk factor. It's often undetected and it's oftentimes inadequately treated, but we know that inadequately treated and untreated hypertension carries a very high risk for stroke. Heart disease, including atrial fibrillation, a history of a myocardial infarction or cardiomyopathy is going to increase the risks for a stroke. Women who drink more than 1 alcoholic drink per day and men who drink more than 2 alcoholic drinks per day are at higher risk for hypertension, which ultimately increases their chances of a stroke. Anybody with a history of or current illicit drug use, especially cocaine, is going to be associated with a higher stroke risk. And somebody that follows a diet high in fat, low in fruits and vegetables will also have increased risk. A transient ischemic attack, otherwise known as a TIA, is a brief episode of neurologic dysfunction without any actual acute infarction of the brain tissue. TIAs produce stroke-like symptoms that generally last about 1 to 2 hours. It's important to teach the patient to seek treatment for any type of stroke symptoms, even if it is potentially just a TIA, as there's actually no way to predict if a TIA is going to resolve or if it is in fact the development of a stroke. TIAs need to be treated as medical emergencies just as strokes do. In general, 1/3 of the individuals who experience a TIA will not experience another event. However, 1/3 will have additional TIAs, and the final 1/3 will progress to a stroke, with half of those having the stroke within a year of the onset of their transient ischemic attack. TIAs are generally due to microemboli that just temporarily block the blood flow through the vessels. The signs and symptoms of a TIA depend on the blood vessel that is involved and the area of the brain that is temporarily being robbed of oxygen. Because TIAs are warning signs of progressive cerebrovascular disease, it's important to initiate preventive drug therapy at this first occurrence of a TIA. Preventive drug therapy would include medications such as aspirin. This is one of the most frequently used antiplatelets in the treatment of TIAs. The common doses for aspirin are 81 to 325 milligrams given daily. Other antiplatelet therapy could include medications such as taclopidine, clopidogrel, or dipritamol. For patients with atrial fibrillation, oral anticoagulation usually includes medications such as warfarin. They may also use medications like rivaroxaban or dabigatran. These are brand names known as Xarelto and Pradaxa. Warfarin obviously requires the weekly INR monitoring, and it does require some dietary management. Even once warfarin levels stabilize or the INR stabilizes, it still does require some periodic blood level monitoring. A primary advantage of the rivaroxaban or the dabigatran over the warfarin is that those drugs do not need the close monitoring that warfarin does, and they don't usually need the dosage adjustments that warfarin usually does or the dietary management. Other medications that would be considered for patients with TIAs who are at risk for a stroke, in prevention efforts, they would look at putting them on the statins such as simvastatin or lovastatin. These can reduce the total cholesterol and therefore reduce the atherosclerosis buildup in the vessels, ultimately reducing the risk for a stroke. Some patients with TIAs may be candidates for surgeries, in a couple of different types of surgeries actually, in order to limit the potential for them to have a stroke. One surgical procedure that may be done would be the carotid endarterectomy, which would remove the plaque buildup from inside the carotid artery. This would be considered if there is a significant amount of buildup noted in that carotid artery. The more the buildup of the plaque is on those carotid vessels, the more likely that patient is to actually suffer some permanent damage due to a stroke in the near future. Transluminal angioplasty and stenting is another procedure that can be done. This helps to open up blocked blood vessels using small plastic tubes and a balloon on the end. Obviously, then with that, stents can be placed to decrease the chance of that artery narrowing again. And in extreme circumstances, they can even do what's called an intracranial bypass surgery. So this is similar to the CABG, which you would have talked about in your cardiac course, only it's done on the cerebral vessels instead of the cardiac vessels. And in the intracranial bypass, they actually use an artery from outside the skull and connect it to an artery inside the skull through a craniotomy in order to bypass the blood flow around a blocked artery in the brain. We have two different types of strokes that we're going to look at. We're going to look at the ischemic stroke and we're going to look at the hemorrhagic stroke. About 80% of all strokes are ischemic. Ischemic strokes can be thrombotic or embolic, as mentioned earlier in the lecture. This depends on whether they were caused by plaque buildup or whether they were caused by a blood clot. The extent of the stroke depends on the rapidity of the onset, the size of the damaged area, and any presence of collateral circulation. Most patients with an ischemic stroke do not have a decreased level of consciousness in the first 24 hours. However, ischemic stroke symptoms can tend to progress over the first 72 hours as the infarct and the cerebral edema both increase. As mentioned already with the ischemic stroke, they can be thrombotic. Thrombotic strokes occur when there was an injury to the blood vessel wall and ultimately that led to the formation of a blood clot. However, an embolic stroke forms when an embolus originates elsewhere and then travels to the brain, to the blood vessels inside the brain, causing the stroke. Most embolic strokes or the emboli from an embolic stroke usually originates in the endocardial layer of the heart. This can be plaque that actually breaks off from the endocardium and enters circulation, ultimately traveling to the vasculature in the brain. Other heart conditions also that can be associated with emboli could be atrial fibrillation, which can lead to the development of clots within the atria. Those clots that form in the atria can travel as well to the vasculature inside the brain. Atrial fibrillation is responsible for about 20% of all strokes. So that's a pretty significant percentage of strokes that atrial fibrillation usually is responsible for. A less common cause of an embolic type of stroke could be a fat embolism from a long bone, such as the femur type of fracture. Embolic strokes do tend to occur more rapidly than the thrombotic strokes. The patient does usually remain conscious and they usually complain of a headache. Prognosis with these types of strokes are going to be related to the amount of brain tissue that has been deprived of the blood supply. Unless embolic strokes, or unless the underlying cause of the embolic stroke is identified and aggressively treated, patients who suffer from an embolic stroke are at high risk for recurrence. Again, unless that underlying cause has been promptly identified and treatment is began. Hemorrhagic strokes, on the other hand, are going to occur due to bleeding within the brain that has been caused by the rupture of a vessel. Generally, the symptoms are a very sudden onset with the hemorrhagic strokes. They can progress over several minutes to hours because of the ongoing bleeding, and prognosis is much poorer with the hemorrhagic stroke. Hemorrhagic strokes carry a 30-day mortality rating of about 40 to 80%. Most hemorrhagic strokes are caused by aneurysms, but other causes can include vascular malformations, coagulation disorders, patients who are on anticoagulant or thrombolytic drugs, trauma, brain tissues, and cocaine use can all lead to the increased risk for hemorrhagic strokes. In regards to the mortality associated with hemorrhagic strokes, about 40% of individuals who have a hemorrhagic stroke due to a ruptured aneurysm die during their first episode. About 15% of those individuals die from subsequent bleeding. Sometimes patients may have warning symptoms of a ballooning artery as it applies pressure on the brain tissue. These can be minor. There can also be minor symptoms from the leaking of an aneurysm before a major rupture. However, the majority may not have any symptoms at all or warning signs of the aneurysm until the full rupture has occurred. Stroke symptoms generally come on suddenly without warning. The only warning that an individual may have that they are at risk for a stroke is if they've previously suffered from the TIA. The neurologic manifestations do not significantly differ between ischemic and hemorrhagic strokes. However, some differences in symptoms can be seen depending on the side of the brain that was affected. So we look at right brain damage versus left brain damage. And it's important to be familiar with the different symptoms that you will see with the different sides of the brain that are affected. So first, let's take a look at individuals who suffer from a right brain injury. Those individuals will first have left-sided motor deficits. So right brain damage causes left-sided motor deficits. So that's going to be paralysis or hemiplegia on the left side. Additionally, with your right brain injured individuals, they also tend to experience what we call left-sided neglect, which leads them to ignore or neglect the left side of their body. Some other manifestations that we see with the right brain injury are that these individuals tend to be impulsive and to move quickly. This puts them at risk for falls. They may try to rise quickly from a wheelchair without locking the wheels or without raising the footrest, again, putting them at increased risk for injury. Additionally, they also try to deny or minimize their limitations. This also creates additional safety concerns as they're more likely to attempt things independently that they are not able to safely do. Another problem with the right brain injured individual are that vision problems tend to be more prominent as well. Again, increasing the safety risks for this particular individual. With left brain injured individual, again, we're going to see right-sided motor deficits. So that's right-sided paralysis or right-sided hemiplegia. Left brain injured individuals are more likely to have problems with memory. They have a higher tendency for issues with speech and language problems. Oftentimes, the left brain injured individual is very cautious in making judgments. They move very slowly and cautiously, for example, say from the bed to the chair or from the bed to the wheelchair. Because they are cautious, slow, and they are also more aware of their deficits, they can be less of a safety risk than that right brain injured individual. However, a special consideration here is that because they are more aware of their deficits and they're more aware of their limitations, this leads to an increase in depression and anxiety with the left brain injured individual. Patients with either type of stroke can have difficulty making generalizations, which can interfere with their ability to learn. Strokes also have an effect on many body functions, obviously including motor activity, but we can also see problems with bowel and bladder elimination. We can see problems with intellectual function, spatial, perceptual alterations, which we're going to talk about here in a moment on a different slide, as well as alterations in their personality, their affect, their sensation, swallowing, and communication. Symptoms caused by the destruction of the motor neurons is what leads to the motor function impairments, which does become one of the most obvious effects of a stroke. These impairments include problems with their mobility, potentially problems with their respiratory function, obviously problems with their swallowing, their speech, gag reflex, and their self-care abilities. An additional assessment question that needs to be asked to a patient with a stroke or to the immediate family who's brought the patient in is to find out the time of onset of these symptoms. This is important for all types of strokes, but is especially important for the ischemic stroke as it can affect treatment decisions, as when we know what time or how long these manifestations have been present in the individual. Talking a little bit more about some of the stroke manifestations that we can see, we're going to discuss one, impaired communication. The left hemisphere is dominant for language skills in a right-handed individual, and in most left-handed individuals as well. Aphasia occurs whenever the stroke damages the dominant hemisphere of the brain for that particular person. Language disorders can involve problems with expression and comprehension of both written and spoken words. This is referred to as aphasia. We have three different types of aphasia to be familiar with. First, receptive aphasia is when an individual has difficulty understanding speech, so understanding the spoken word. Expressive aphasia is when there is an inability for them to produce intelligible speech. So with expressive aphasia, they may understand what you're saying to them, but they cannot express themselves and they can't appropriately say what it is they want to say to you. Global aphasia is when there is a total inability to communicate. All communication and receptive function are lost. Massive strokes have the potential to result in global aphasia. Aphasia can also be a mix of what we call non-fluent and fluent, when there is an impairment in both expression and understanding. Non-fluent aphasia is when there's minimal speech activity with very slow speech. Fluent aphasia is the speech is present but contains little meaningful communication. So for example, the individual is able to state words that you understand, but the words are not connected to each other and they don't flow into a normal conversation or even make a normal sentence. Another problem with communication is the term dysarthria. Dysarthria does not affect the meaning of the communication or the comprehension of it. Dysarthria specifically affects the mechanics of speech, mainly the ability to move the muscles to produce sound and to produce clear speech. A lot of patients experience a combination of some type of aphasia as well as dysarthria. In regards to affect, the stroke patient can generally have difficulty controlling their emotions. This can be that they cry frequently or suddenly, and they also can have a tendency to become angry easily. Intellectual function is also likely going to be affected to some degree in the stroke patient, with both impairment of memory and their judgment. As we go on, we take a look at their problems with spatial or perceptual alterations. This can include denying the illness or denying a part of their body. It can lead to problems with denial of sensory input for one side of the body. We tend to see these spatial perceptual alterations more often in the individual with the right brain damage. However, we can see them in people with the left brain damage as well. Generally, spatial perceptual problems get divided into 4 categories. The first category is when the patient has the incorrect perception of their self and illness. As I mentioned, that the first one is that they have the denial of the illness or of a part of their body. The second category for the spatial perceptual alterations is when they neglect input from the affected side, as I mentioned with the denial of sensory input for one side of the body. One way that this can be worsened is by the condition known as homonymous hemantiopia. This is when blindness occurs in the same half of the visual field of both eyes. So this would mean that they would lose half of the visual field on either the left side of both eyes or on the right side of both eyes. Patients with this condition also have difficulty with spatial orientation, such as judging distances. The third category of spatial perceptual alterations is agnosia. Agnosia is the inability to recognize an object by sight, touch, or hearing. This is different from stereognosis, which was the ability to recognize a familiar object with their eyes closed. So again, agnosia is their inability to recognize an object by looking at it, by touching it, or by hearing it. An example would be something that we are all familiar with, such as change. So the individual could look at a handful of change, which is something that should be easily recognizable, and they're unable to state for you what it is by looking at it. It could be the ringing of a telephone. They've heard that sound before, but following the stroke, they're unable to verbalize, again, what that sound is. The fourth deficit, or the fourth category with spatial perceptual problems, is apraxia. Apraxia is the inability to carry out a learned sequential movement. A best example of this is tying your shoes. Tying your shoes involves several steps. It's something that an individual would have learned years ago, but again, following a stroke, if apraxia develops, they're going to be unable to carry out those learned sequential movements that they've been familiar with in the past. Patients may or may not be aware of their spatial perceptual alterations, so it is important for nursing staff and therapy staff to assess for this potential problem, because any of these issues can impact the patient's rehab efforts and their recovery.